In this video, I'm going to be talking about the esophagus. I'm going to go briefly through the anatomy of the esophagus, then I'll talk about the most common conditions that are encountered during medical exams. The esophagus is a fibromuscular tube that is approximately 25 centimeters. It extends from the inferior border of the cricoid cartilage at the level of C6 vertebra to the cardiac orifice of the stomach at the level of T11 vertebra. It has three anatomical segments: the cervical segment, which is approximately 5 centimeters, the thoracic segment, which is approximately 20 centimeters, and the abdominal segment, which is approximately 2 centimeters. We have two sphincters: the upper esophageal sphincter, which is defined by the cricopharyngeus muscle, and the lower esophageal sphincter, which is defined by the gastroesophageal junction, the arterial supply. The upper esophagus is supplied by the inferior thyroid artery, and down there it is supplied by the left gastric artery and the left inferior phrenic artery. Venous drainage. The esophagus is drained by the azygous veins, the inferior thyroid veins, and the left gastric vein. And it is innervated by the 10th cranial nerve, the vagus nerve. Achalasia. Achalasia is a neurogenic motility disorder that is characterized by impaired peristalsis of the esophagus and lack of lower esophageal sphincter relaxation during swallowing. The patient presents with dysphagia for both solids and liquids, and this is a very important feature because it can differentiate it from other conditions. Diagnosis is made by esophageal manometry, which shows an incomplete relaxation of the lower esophageal sphincter plus 100% failed peristalsis. Barium swallow can also be used, and you can see the rat tail sign or the bird's beak sign, which is a characteristic of achalasia. Treatment is usually done by endoscopic dilation of lower esophageal sphincter or surgical myotomy of the lower esophageal sphincter. Gastroesophageal reflux disease. That is like the opposite of achalasia, in which there is an incompetence of the lower esophageal sphincter, which allows the reflux of the gastric contents into the esophagus. The patient usually presents with a burning chest pain that is referred to as heartburn. Prolonged regurgitation may lead to esophagitis. Diagnosis is made clinically, so a proper history can guide you right to the diagnosis. Endoscopy is considered for patients who are not responding for initial treatment. Barrett's esophagus, which refers to a columnar metaplasia, should be excluded because it's precancerous. Treatment include lifestyle modification like elevating the head of the bed, avoiding certain things like strong stimulants of acid secretion like caffeine or alcohol, certain foods like fatty food or chocolate, and last but not least, smoking. Drug therapy include proton pump inhibitors and H2 blockers. Fund application is indicated for patients with high-grade esophagitis or large hiatal hernias. Esophageal diverticula. It's an outpouching of the mucosa through the muscular layer of the esophagus. It can be asymptomatic, or it can lead to dysphagia and regurgitation. There are several types of esophageal diverticula. Each has a different origin. The Zenker's diverticula, which is a posterior outpouching of mucosa and submucosa through the cricopharyngeal muscle. The mid-esophageal traction diverticula, which are caused by traction due to mediastinal inflammatory lesions. The epiphrenic diverticula, which are just above the diaphragm. They usually accompany motility disorders like achalasia. Diagnosis is made by barium swallow or sometimes upper endoscopy. There is no need for treatment, but surgical resection may be required for symptomatic or large diverticula. Hiatal hernias. The hiatal hernia is a protrusion of the stomach through the diaphragmatic hiatus. Most hernias are asymptomatic, but an increased incidence of acid reflux may lead to symptoms of gastroesophageal reflux disease. There are two main types of hiatal hernias. The first type is the sliding hernia. This type is the most common type, and in this type, the gastroesophageal junction and a portion of the stomach are above the diaphragm. The second type is the paraesophageal hernia, which is also called the rolling hernia. In this type, the gastroesophageal junction is in its normal location, but a hernial sac containing the gastric fundus and body develops alongside of the esophagus. Diagnosis is made by barium swallow or upper endoscopy. A large hiatal hernia is often discovered incidentally on chest X-ray. Asymptomatic sliding hiatal hernia requires no specific therapy. For patients with accompanying gastroesophageal reflux disease, therapy with proton pump inhibitors should be considered. For paraesophageal hernias, repair should be considered because there is a risk of strangulation. Esophageal cancer. We have squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma can arise anywhere in the esophagus, but almost all tumors of the upper esophagus are squamous. Adenocarcinoma arises in the lower third of the esophagus, either from Barrett's esophagus or the cardia of the stomach. The patient can present with dysphagia for solids and weight loss. Cachexia and cervical lymphadenopathy may or may not be there. Endoscopic ultrasound permits lymph node sampling and assessment of the depth of tumor penetration. Thoracic and abdominal CT scans can be used to define metastatic spread and local invasion. Approximately 70% of patients have extensive disease at presentation. The treatment usually includes surgical resection combined with chemotherapy and radiation. That's all that I have for this video. I hope you enjoyed it, and thanks for watching.